Welcome to the Rocky Mountain MS Center's webinar series. This series is designed to give people with MS information to empower them to make the best choices for their lifelong brain health. I'm Kelsey Morrow, Education Manager at the Rocky Mountain MS Center, and I would like to thank the pharmaceutical companies who have provided support for this program. Thank you to Bristol Myers Squibb, EMD Serono, and Novartis Pharmaceuticals. This series is just one piece of our education programming. We have a variety of formats available to you, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. Our most recent videos are from our series Conversations on MS, which is a 90-minute town hall style Q&A with the MS specialist neurologist from the Rocky Mountain MS Center. And the videos include a clickable index of topics discussed. You can join the next session live with Dr. Andrew Wolf on July 11th, either online on Zoom or in person in Grand Junction, Colorado. We announce upcoming educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. All of our education programs are free of charge to anyone interested. Today's presentation will discuss the extension data from the DISCO-MS trial, as well as some other important research updates. Our presenter is Dr. John Corboy. Dr. Corboy is the former medical director of the Rocky Mountain MS Center, retiring from daily duties in 2024. He's a graduate of the University of Pennsylvania and did his neurology residency there with a fellowship at Johns Hopkins University in Baltimore. He specialized in MS and neurovirology at the University of Minnesota Medical Center before coming to Colorado in 1994. He is the founding editor of Neurology Clinical Practice, the clinical journal of the American Academy of Neurology, retired director of the Rocky Mountain MS Center at University of Colorado, and retired medical director of the Rocky Mountain MS Center. This webinar features a lot of important information. If you missed something on a slide or want to hear it again, we are recording it and it will be archived on our website so that you can replay it at any time. All live viewers will automatically get the recording sent to them. You will also receive a link to our evaluation survey. Please take a moment to fill that out as it helps us improve future programming. We'll reserve time at the end to answer questions from the audience. You can submit questions at any time using the Q&A box on Zoom. We did have a large number of questions submitted at registration, many of which will be answered in today's presentation, and then we'll answer as many additional questions as time allows. Today's presentation is for educational purposes only, and we are unable to answer questions that are very specific to your personal situation. All treatment decisions should be discussed with your own neurologist. With that, I'll turn it over to Dr. Corboy.
Great. Thank you very much, Kelsey. I appreciate the opportunity to join everybody today, and I appreciate you taking time out of your busy schedules to join us. And I'm going to put my screen up there. And all right, so these are my disclosures here. And I'd like to talk just briefly about diagnosis of MS. As I'm sure you're all aware, diagnosis is perhaps the first most important step that we take in trying to get at this condition. And we've gone through many iterations over the course of the last 20 years or so with the so-called McDonald criteria. And although these are not yet published, the 2024 McDonald diagnostic criteria has some interesting changes. As many of you are aware, we've always tried to say that MS is a diagnosis of abnormalities or lesions that are disseminated in time, and that is over different time periods, either with episodes or with slow progression over time, and also with lesions disseminated in space in different parts of the central nervous system and optic nerve. And there's always been a requirement for both, but over time, as MRIs have evolved and our knowledge about the distribution of the lesions has evolved, DIS, or dissemination in space, has gained predominance, and it's even more so now in this. So now we've added a fifth location of the typical locations for MS lesions, the optic nerve, which was strangely left out, even though it's a very typical attack in MS. So I'll show those in a second. DIT, or dissemination in time, is no longer required if specific DIS conditions are met. And this allows us to actually even diagnose MS in so-called radiologic isolated syndrome, where people have clinical syndromes that are not anything like MS, but have an MRI scan, maybe after headache or a car crash, and yet they have lesions that look like MS. We can now diagnose that even without clinical symptoms typical of MS if you have certain circumstances. And we have some new laboratory tools, either in the spinal fluid with so-called kappa-free light chains, which is another way of essentially showing the same thing as oligoclonal bands, which we've been looking at for 60 or 70 years. Then also a couple of new MRI signs, the central vein sign and paramagnetic rim lesions. And so we've, for the last many years, been using four typical locations: a spinal cord here, and hopefully you'll see my arrow, cortical lesions out in the outer rim of the brain, the so-called classical Dawson's fingers, which are these lesions next to the ventricles in dark here where the spinal fluid is made, and then this perpendicular line here with the arrow is the so-called Dawson's fingers, deep in the middle of the brain. In the back of the brain, the cerebellum and the brain stem. And then now the optic nerve showing brightness there compared to the other side. We also have so-called paramagnetic rim lesions, some call them phase rim lesions, that you can see here. And then also the central vein sign, you can literally see a vein going right through this Dawson's finger here. And those two new MRI scan signs show substantial specificity and help with the sensitivity as well. And to show what they really mean pathologically, the paramagnetic rim lesions are really rims of what we see as really the iron that's actually in the microglia macrophages, these scavenger cells that pick up damaged material in many different organs, including in the brain, microglia being specific to the brain. And you can see these lesions relatively specifically, for example, here with a rim around there and a rim around this lesion here.
Dr. Corboy, we can't see your cursor, but if you use the annotate feature, you can change to the cursor.
Oh, how do I do that, Kelsey?
On mine, it's on the left side screen. It says annotate.
I have a pen or a laser pointer.
Try the laser pointer.
Let me try that. Um, Laser pointer. How about, can you see it now?
Yes, thank
So
you.
you can see there's a rim around this lesion here. Why do we care about this? From a diagnostic point of view, although there's not great sensitivity, that is, many people will not have phase rim lesions or paramagnetic rim lesions, but if you see them, they're almost always 100% of the time in this one study, 99.7% of the time, consistent with multiple sclerosis and no other condition. So that is incredibly helpful in terms of making a diagnosis. And when we want to talk about how dissemination in space has then evolved, so now if you have lesions in two of the five typical topographies that I showed a moment ago, any two of those, then you fulfill dissemination in space. So in order to fulfill diagnostic criteria for MS, you could do it the old-fashioned way, have dissemination in space plus dissemination in time. By the older criteria, you fulfill diagnostic criteria. You could have dissemination in space just plus either oligoclonal bands or the kappa-free light chains in the spinal fluid, and that would give a diagnosis. You can have patients with typical symptoms, say a spinal cord syndrome, and typical lesions in at least four of the five locations, and with nothing else, no spinal fluid, nothing else, no change over time, that gives you a diagnosis. In patients with typical symptoms and typical lesions in only one topography, say spinal cord, then if you add some of these other things, like the presence of so-called select 6 for central vein sign or paramagnetic rim lesion plus dissemination time or spinal fluid abnormalities, that will make it. So again, even after just typical symptoms once. And in progressive MS, it used to be you had to have two of three things, either abnormal spinal fluid plus or minus two spinal cord lesions plus or minus a single brain lesion. Right now, you can make the diagnosis with typical progressive disease and just two spinal cord lesions, and that is enough to give you DIS, and you don't need any brain lesions for DIS, and then you just have to fulfill dissemination in time, the various other ways that you can do that. So these are important changes. And the radiologic isolated syndrome is one example of how this has changed the functioning. In that you can, for example, have, again, someone with no clinical symptoms at all, but they fulfill dissemination in space and either can do dissemination in time with new MRI scan lesions later, or you can add oligoclonal bands, or you can have this select 6 central vein signs. All of those with no clinical symptoms would make a diagnosis of multiple sclerosis. And importantly, there's been a recognition in the last 50 years or so, really more 25 years, of diagnosing people with onset much later in life, and a diagnosis even after the age of 50 or even 60. And there's caution with this because many of the lesions that we see on scans that are consistent with MS may be consistent with other things, especially vascular disease or with migraine. And so, in order to try and avoid the problem of diagnosing someone, say, with hypertension on their brain scan, it's really important that you look for spinal cord lesions, that you then get positive spinal fluid, or that you have the CVS, central vein sign select 6. These are strongly recommended to make a diagnosis over the age of 50. Which leads to a question, what about what for many people would be a time that they would maybe be being considered going off medications because they would have maybe been on for 20 or even 30 years already now, the first medicine being approved in 1993. So we've had these drugs now for 32 years. And so many people have even stopped using their medications by the time we're talking about 50 or 55. And the natural history of MS, many of you have probably seen this before. We know that we usually see people when they have their first initial event, say an optic neuritis or spinal cord syndrome. And over time, they may have more clinical attacks or may have slow progression, but this is talking about relapsing forms of MS. And many patients will have a diminishment in relapses over time. But what they do start to see is that there can be a slow progression of disability in some, not all patients over time, with many less, if any, relapses as people age, especially after 45 or 50. And then we also see, for example, that the accumulation of lesions on the scans untreated, these will just increase over time. But the new active lesions after the injection of contrast material, these so-called enhancing lesions, they actually diminish with time. And so what also happens is we may see some cognitive impairment that worsens associated with the same change in physical function, like with walking, but also brain volume will shrink. These are normal changes that occur clinically over time. And so what does this mean when we think about what the logic might be for eventual discontinuation or de-escalation of disease-modifying therapies? There's a clinical and radiologic changes I've shown here. These are associated with pathological changes where you have what's called innate immune system dysfunction, which is more prominent. I mentioned the macrophages and microglia previously. While those are very active early, they are more important even later, especially when people have progressive disease or PIRA, progression independent of relapses as people age. The presently available disease-modifying therapies, the DMTs, are really not directed against the innate immune system, though. They're directed more against the adaptive immune system, which is active when people are much younger typically, and have their greatest impact on relapses in these active lesions. And the available data supports that the concept that these benefits wane with age. And interestingly, and somewhat unfortunately, there's very proven benefit over age 55 of the present available DMTs because mostly people over 55 have been excluded from trials for the reasons I mentioned before, because of the confusion with, for example, lesions with vascular disease on brain scans. We also know that the risk of at least some DMTs may be greater in older patients with infections, cancers, or diminished response to vaccinations, especially with regard to depleting agents such as Ocrevus, rituximab, Briumvi, Kesimpta, Lemtrada, and Novantrone. Those agents that really remove cells are associated perhaps with greater risk beyond that, which is just seen with people as they age. And also we know that some comorbidities, diabetes, high blood pressure, cancer may limit the use of some drugs in older patients because they already have those conditions. But the reality is that many people have already stopped DMTs as they age, as they've hit 55 or 60. And we know that people who continue often have lower quality of life scores. But if you look at people who actually are aging with their MS and are still on DMT, their willingness to consider a trial off medications is low. And I'll show that slide later. So we have the classic issue that we face in everything we do in medicine, where we're balancing benefits and risks of the medications, where the benefits may be going down over time and the risk perhaps going up, but we always want the benefit to be greater than the risk. And so this is what we see when we first put someone on medications. And that's also what we see as people age with their MS, especially as the nature of the disease changes. And there have been numerous observational trials. These are just people that say, hey, this is what we see in our database. This is what we see in our practice, looking at potential discontinuation since really over 25 years ago. All the ones in yellow are those ones that were published after the start of the DiscoMS study that I'll mention in a minute. And the Prosperini article in green is a so-called meta-analysis where they collected all the studies before that. And they said, hey, what can we glean if we put these all together? And what they gleaned was that if you've been on medication for more than 10 years, if you are stable for more than 8 to 10 years, but importantly, if you're over the age of 60, the likelihood of having a relapse is very low. Most of the information from here has to do with whether or not you have a risk of new relapses or new scan changes, but there is some data also looking at risk of progression of disability as well. But none of these, very few of these studies, not none, the Huast paper here, that actually looked at very specific populations, older populations, and also another paper by Lei Hua back here looked at people only over the age of 60. But otherwise, most of these looked at broad populations, not just specifically older age populations. But there are now 4 randomized trials, 2 in yellow marked here that have been completed, our DISCO study and the DOT-MS study from the Netherlands that I'll show you, and 2 more from France in secondary progressive MS and relapsing MS that have similar approaches, all randomized controlled trials, prospective, looking at people in 2 different groups over time and then following them, and looking mostly, as you can see, with the older injectable drugs or Tecfidera, dimethyl fumarate, or teriflunomide, Aubagio, most commonly in all of these studies. But there's a few patients who are on some of the other medications, including in DiscoMS. So many of you know about DiscoMS. It was published almost exactly 2 years ago to the day from now. And just to remind people, it was a randomized controlled trial, rater blind. As people who were interpreting the data were blinded to whether someone was on drug or off. Had a mean follow-up of 22 months. You had to be a minimum of 55 to get into the study on an approved DMT for the last 5 years, the last one for at least 2 years, no relapse for 5 years, no MRI activity at all that's new for 3 years. And we looked at new relapses and or new expanding brain lesions, any new MRI scan lesion, with secondary outcomes of change in the EDSS for progression of disability, the SDMT for cognitive function, a variety of patient-reported outcomes, the patient-determined disease steps, which is very similar to the EDSS, but the patient tells us about their experience with it, and then the patient satisfaction question. And we asked the question, is going off drug not inferior? Can we demonstrate that it's not inferior to staying on the medicine with a margin, that is an 8% margin around which we would say over the 2-year period, if 8% or less of people had a higher proportion by 8% of the outcome measure than the people who stayed on medication, we would call that non-inferior. And this was funded by public sources, PCORI, and the National MS Society. And I want to focus only on a couple of things here with the arrows. The average age in the continuers and the discontinuers almost identical, 62, 63. Vast majority of women, 4 to 1 in this study, almost 5 to 1. About 8 or 9% African American, mostly white. Over 21 to 22 to 23 years since symptom onset, 13 to 14 years since last relapse, and a moderate level of disability on the EDSS, which is a 10-point scale, higher scale being more disabled. This is considered a moderate disability and almost identical between them. And here's the distribution of the drugs that people were taking, and most people had relapsing remitting MS. And this is the statistical portion of the talk. If we could show that number, that 8%, the proportion difference between discontinuers and continuers was 8% or less, including the error margins, the so-called 95% confidence intervals, all in less than 8%, then we can say that we demonstrated non-inferiority. On the other hand, if that number was outside the 8%, the proportion difference, and the 95% confidence intervals were also beyond the 8% margin, well, then we could actually show that the new treatment, in this case going off drug, was actually inferior. The third possibility is that the proportion of difference could be, say, 7%, but the error bars were outside of that. The confidence intervals were outside of that statistically, in which case we could say that we couldn't demonstrate in non-inferiority, but we also couldn't demonstrate inferiority. So we'd have sort of a mixed message. And in fact, we got the mixed message as the main outcome. Because when we looked at the primary outcome of relapse plus or minus a new or enlarging brain MRI scan lesion, the difference was under 8%. But the confidence intervals, 0.6 to 15%, were outside of that 8% margin. So this was a non-significant statistical value. If we looked just at relapses and we did in a post hoc analysis, there were so few relapses, only 1 in the continued group and 3 in the discontinued group. This would have been a significant outcome. If we looked at just the new brain lesions, that's where the difference really was. Most of the difference between the two groups was in the different lesion in the brain lesions, almost 7% difference, not statistically significant. The other main outcome we looked at was progression of disability, and there was really no difference between the two in terms of progression of disability. 11% versus 12%, this was not significant. So the main finding from here is that the vast majority of people who had new disease activity had 1 or 2 new dots on their brain scan, and very little difference in terms of relapses, and very few people that had significant, say 3 or more lesions or 4 or more lesions on their scan. So the vast majority of this was 1 to 2 new lesions that had no clinical accompaniment with it. And so if we look at just the people who discontinued DMTs and looked at those with new activity versus no new activity, one question would be, well, were they particularly younger? Did they have some other major features? Not particularly. The average age is maybe a little bit younger, maybe a little bit more men compared to those with no new activity. We know that men have a more challenging time with MS than women typically. But about the same amount of time since onset of disease, about the same amount of time since last documented relapse, about the same amount of time, same amount of progression of disability. And if anything, they just had more that were categorized as relapsing remitting MS, but that was not statistically significant. So they look much more alike than different. So I want you to keep that in mind as we go forward and look at a couple of other things. And as I mentioned, only 2 people out of all of these people had both new activity with a relapse or scan change and progression of disability. And so was there a relationship between having new dots on your brain scan or a relapse and having progression of disability? The answer was no. When we also looked at the cognitive test, the SDMT, the various patient-reported outcomes and quality of life, the PDDS, there really were no differences between the continuers and the discontinuers. And as noted on this slide, there's greater patient satisfaction over time with those who actually went off of drug. And when we looked at those at baseline, and red was the discontinuers and the blue was the continuers, they were almost identical. But over time, there's a slow but significant increase in the discontinuers in terms of their patient satisfaction with their disease-modifying therapy, whereas it was almost identical from beginning to end, except for this blip up at 18 months, almost identical for those who remained on drug. And this difference was significant at the end. So we were able to get a small amount of money from EMD Serono, and we appreciate that, to do an extension with a limited subset of the patients. And we looked at the 10 largest recruiting sites of the 20. And we asked that people have completed the original trial to at least 18 months, did not meet the primary original endpoint because we didn't want to sort of count people twice, if you will. They had to stay on their original assignment, continue or discontinue. So this was no longer a randomized controlled trial. We're just looking to see what happened with people over time who were randomized to the 2 groups, because now people have actually elected to either stay on or off drug after the original trial ended. They had 1 visit, which was identical to all the DISCO visits. We now had a mean follow-up of 38 for continuers or 41 months for discontinuers. And now we didn't have statistical power to do a non-inferiority analysis. So we just looked at the time to event of relapse or new MRI lesion. And we already showed in the first study that that was a little bit faster in the group that discontinued. So what did we see? All participants are noted here, and the mean ages in the continuers and discontinuers, slightly younger in continuers, time since onset of symptoms, perhaps a little bit younger in continuers. Number of years since last documented relapse, a couple of years younger in continuers. About the same amount of disability, almost very similar to what we saw in the primary study. And now we had almost all relapsing remitting MS patients, very few of the progressive patients entered the extension trial. And so what did we see? We didn't see much. We had a total of 74 patients, 30 continuers and 44 discontinuers. We saw no new relapses. 1 out of 30 continuers had new MRI lesions, had 2, and 2 out of 44 discontinuers had either 1 or 3 new lesions. And that was the main difference. And again, the differences in all the other things that we measured were very modest, if any. And again, there was greater treatment satisfaction amongst the discontinuers compared to the continuers. And here's that Kaplan-Meier survival curve saying, what is the likelihood that you will stay without hitting the primary outcome, and when do you hit that primary outcome? And we could see that at 24 months, there was a slight difference between these two at the end of the original trial. And then there were just a couple more events that occurred. And the notable thing here is that the individuals having new disease activity with a relapse or a scan change sort of flattened out. And there was not this continuous new degree of new activity that was seen. So about 80% of people who went off drug had some element of new disease activity over 4 to 5 years. So the main takeaway from that is that there are small changes that are likely to occur at a greater rate when you discontinue drug, even in the context of a patient looks like a disco MS patient. But the vast majority of times, it's just 1 to 2 new dots on the brain scan of unclear clinical significance. So our colleagues, especially Eva Strebus in Amsterdam, did a very similar study with some important differences. They would accept people as young as 18, could have been diagnosed when they were 13, and 5 years later, they're 18. They could have gone into the study. Now, they didn't have anybody that young, but it's otherwise a very similar study. They looked only at the old injectable drugs, Tecfidera and Aubagio as well. They looked only at relapse onset patients, so they didn't include primary progressive. And you had to have no relapse for 5 years and no significant MRI activity. That is, they allowed at least 1 new dot on your brain scan in the last 5 years, but nothing more. And they had a very similar endpoint, either a clinical relapse and or new MRI activity, but they looked at significant MRI activity, either 3 new T2 lesions or 2 or more contrast-enhancing lesions, as opposed to, for us, any new lesion, any 1 single new dot. So ours was a more stringent outcome than theirs, but they looked at more significant MRI activity. There's data that supports the idea that 1 or 2 new dots over time probably does not have a big impact in terms of change in disability 5 to 10 years later. And that's why they chose this. And here's what their population looked like. Continuers on the left, discontinuers on the right. And this was published last year in December. They were an average age 54 to 55 or so about 8 or 9 years younger, 7 or 8 years younger. They had about twice as many males, so a little bit more male-oriented, if you will, but still mostly females. 13 to 14 years since onset of disease, 9.5 or so years since last relapse, and then slightly less disabled than our population, reflecting being slightly younger. So similar, but everything frame shifted down about 6, 7, 8 years. And what did they see? With their primary outcome of a relapse or significant MRI activity in the continuers, they only had 44 continuers, 45 discontinuers because the study was stopped early. And it was stopped early because 0 continuers versus almost 18% of discontinuers had significant new activity. And the study was stopped by their Data Safety Monitoring Board because that was felt to be an excessive amount of new activity. Now, most of this was still significant MRI activity because there are, again, very few relapses. When they counted the same way we counted any new relapse or new MRI activity, they had about 24% amongst continuers and 2.3% amongst the discontinuers and 2.3% amongst the continuers. So they did count the way we did as well. and notably no difference in progression of disability similar to us, but slightly more people had progression of disability compared to our study. And who were the people that had new activity? Here's the activity and here's the no activity people. When you mix all of them together, all 89, the median age was 46, the mean was 49. So these were younger patients compared to the patients who had no new disease activity. And notably, they had much longer follow-up amongst the people with activity. Had they followed the same people in the no activity group for longer, they may have even shown more activity. It was only 14 months for follow-up median duration here. When you do a direct comparison of .MS to DiscoMS, here's their 17.8%. Well, if we counted our data the same way they counted, it would have been 4.6%. So over 4 times as much increased disease activity. And here's their 24% compared to our 12.2% if you count the way we counted in DiscoMS, noting that the average age amongst discontinuers was 51 here and 61 in ours. So 10 years younger, twice as much new disease activity, most of it radiologic, is the take-home message from the comparison of these two studies. Both of these studies, though, really looked mostly at the older drugs, the injectable drugs, as well as Aubagio and Tecfidera, but had many fewer patients amongst those taking, say, Gilenya, fingolimod, or natalizumab, Tysabri, or the CD20 drugs like rituximab or Ocrevus. So the French group, the same group that's doing the studies that are still pending, the randomized controlled trials, they have what's called their offset database. It's a very large database of many different groups throughout the entire country of France. And this large database, they routinely collect data, and then they can actually interrogate the database, and they can do what's called a propensity match study. So this is not a randomized controlled trial that's prospective. This is a retrospective study where they look back at the data and they say, okay, well, let's look at all the people who are on those 3 classes of drugs, Gilenya, Tysabri, and the anti-CD20 drugs. And then look at the people who were on those for at least a couple of years, were at least 50 years of age, and compare those who then went off drug and those who stayed on drug. And so they did essentially a pseudo randomized study, a propensity match study, but it's not a randomized controlled trial. And when they looked at it, minimum of 50 years of age, they were about 5 years younger than Disco at 57 or so, 57 and a half. They had a significantly higher EDSS. That is, these are people who had more progressive disease for sure. More than 35% had failed 3 or more medicines by the time they got to these drugs, because in France, to get to use these more highly effective drugs, especially 5 or 10 years ago, you had to fail multiple drugs before you could get the better drugs. And they had a very short time since last new disease activity. It was a minimum of 2 years for a brain scan, or relapse was only 4.5 or so years. So this population was younger with much more active disease over time and more recently than the DiscoMS population. So keeping that in mind. So what did they see? When they compared all 3 of those drug classes, and the ones who went off drug is in orange, those who stayed on drug are in blue, you can see there is a faster time to having, in this case, it's a relapse that was measured. Faster time to relapse, if you look at 2 years, is statistically different when you combine all 3 of those drug classes. When you look at Tysabri alone, it's certainly faster when you go off drug. When you look at Gilenya alone, certainly faster if you go off drug. But that was not true for the CD20 drugs, which were mostly rituximab, but then a couple of patients with Ocrevus. They did note that higher age was associated with a lower risk of relapse, not surprisingly, and being more than 5 years since last relapse or scan change was close to significant. The hazard ratio was reduced by 37%, a 0.63 hazard ratio, meaning that it was about 1/3 less likely in the group with greater than 5 years since last relapse or scan change. This was not quite statistically significant. When they looked at progression of disability, they showed pretty much the same thing. When you look at all 3 drugs together, going off drug at 2 years, it was a faster time to progression of disability. Tysabri alone, faster time. Gilenya alone, it was faster time numerically, but statistically was not quite significant. And again, no difference with the CD20 drugs in terms of progression of disability. So you could conclude from this, at least in this study with this population, that um, that going off drug in this context was perhaps associated with a faster time to relapse and progression of disability, especially for Tysabri and somewhat for Gilenya, not so much for rituximab or Ocrevus. But again, this population looks very different from the DISCO MS study. So it does not answer the question if you had people who look like the DISCO population and were going off these drugs, what that means. I think it's a different population and a different question. But that ultimately leaves us as well that we have this data now. Some people would accept that there's a small increased risk, especially coming off some of the older drugs or Tecfidera or Aubagio. If you go off medications, maybe a slightly higher risk of having one or two new dots on your brain scan, but others may not be interested in. When we started the DISCO MS study, we did a survey of the NARCOMS population, North American Research Committee on MS, and got survey responses from 377 people. Looked somewhat like the DISCO population, except they were a little bit younger, only at 56 average age, but they're all on drug, and asked them just a simple question. Would you be willing to consider going off medication? And only 12% were likely or very likely to consider a trial off medication. 2/3 were very unlikely or unlikely to consider a trial off medication. So a substantial number of people, even though we know that as people age, the number of people on drug goes down, a substantial number of the people who are remaining on drug wish to remain on drug. So are there other options? Would you potentially not discontinue, but maybe de-escalate, try to reduce risk, especially if you're on a more highly effective therapy that may have higher risk? And the logic for potentially doing that is that we know, and this is our own data with over 2,000 patients using either 1,500 on Tecfidera, the dimethyl fumarate, or fingolimod, Gilenya, the oral drugs, compared to Tysabri, natalizumab, or rituximab, or Tuxan. We looked at people who started these drugs and started at different ages. And not surprisingly, we showed the likelihood of having a relapse or a new scan change, an active lesion on your scan, over a 2-year period of time, the likelihood of that went down the older you were when you started this drug, because we know that those things go down as you age. They're just less likely to have a relapse as you age. But interestingly, we showed that the risk, if you're on the oral drugs, the less effective drugs, was higher compared to what it was in the IV more effective drugs, the Tysabri and the rituximab, when you are young. But as you age, those curves start to come together. And at about age 54, they cross. So the extra benefit that you got from the more highly effective drugs was diminished, if not gone, by about age 54. So if there is, in fact, higher risk with Tysabri or with rituximab compared to the other drugs, you're not getting any more bang for your buck. You're not getting any greater benefit. So would you de-escalate, for example, then to a drug that had less risk? And that would be part of the logic as you age if the risks are in fact going up. And so we could also show that we looked at relapses and progression of disability. This study that was just published a couple of weeks ago in the MS journal looked at the effect on the impact on progression of disability as opposed to just relapse or scan changes, and looked at highly effective versus what they call platform DMTs. And in fact, the hazard ratio is about half of that when you looked at the people who are under the age of 45. But if you look at the people over the age of 45, the hazard rate was still less than 1. That is a reduction hazard rate for the people who were using the highly effective therapy. However, this was no longer statistically significant. So for both relapses and for progression of disability, the older individuals do not derive the same benefit as the younger individuals with regard to those two outcomes. So there have been, again, many DMT de-escalation studies. Again, the vast majority of these do not look at an older population specifically, but they too show that the risk of recurrent disease activity is higher in younger people who've had more recent disease activity should you de-escalate. And most of the data is actually in younger patients with relatively recent disease. But there are several different ways that you could actually de-escalate. You can go to a different class of drugs. So for example, if you're on the CD20 drugs and maybe you have a higher risk of infection, maybe change to a fumarate like Tecfidera or an S1P modulator like Gilenya. And those studies are underway, and one of those is published here as noted below. You can lower the dose of the medication. When we first started using rituximab, we were using 1,000 milligrams twice every 6 months. Now we're down to 500 milligrams once every 6 months as the standard, and that there is absolutely data that supports this. You could also go from teriflunomide, Aubagio, from the 14 milligram tablet to the 7 milligram tablet, or fingolimod, Gilenya, from the 5.5 milligram tablet down to the 0.25 milligram tablet. Now, there's data that does not support that, though. Neither one of those appears to be a good choice. You could also lower the frequency of using the drug, and this is especially true for the IV drugs that are used intermittently. And now the standard for Tysabri, natalizumab, has gone from 4 weeks to 6 weeks, or even some people use 8 weeks based on really well-done controlled trials. Similarly with CD20 drugs like Ocrevus and Briumvi and rituximab, the standard has now become, after 1 to 2 or several more years, to challenge not just using it at a lower dose, but going from 6 months to even 12 months or longer. And there's a study that's been started now to actually look at discontinuing this even after just a few years. Would you use trough levels, that is the lowest level in the blood of natalizumab, as a marker of when to go back to take the next dose? Perhaps. Would you use the marker of the actual return of the cells that we're eliminating with the anti-CD20 drugs, like Ocrevus and rituximab? The cells that we're depleting will come back. Would you wait until they come back and then give the dose? Don't know if those things make a difference. We do know that when you lower the frequency of Gilenya, fingolimod, from the 0.5 milligram every day to every other day, it does reduce the risk of rebound of disease activity, but it's not clear what that means in the long run. But ultimately, the ultimate de-escalation is discontinuation. The related question then is, would you go cold turkey? You might be able to do that effectively with, for example, the moderately effective drugs like the older injectable drugs and Tecfidera and the other fumarates and Gilenya, the other S1P modulators, or also with cladribine, alemtuzumab, that's Mavenclad and Lemtrada, as well as the anti-CD20 drugs. But you probably need what we think of as an off-ramp with Tysabri, natalizumab, or fingolimod, Gilenya, and these studies are underway when you transition to cladribine. So cladribine is a drug you might take for a couple of months, 1 year, wait a year, go back and treat again. Has a much longer activity than the short-acting drugs here, like Gilenya or Tysabri. And there are 2 studies, the Cladrina study and the FinClad study. And in the FinClad study, which has been published, when you go off of fingolimod, Gilenya, to cladribine, there's actually a fair amount of activity just at 3 months. 13% of people had new activity at just 3 months. So I'm not sure that this is the best choice in this context. But those are ways that you might consider this. The important part here is that none of this data is really explicitly for individuals who are older, and whether or not this makes a difference is not clear. So our conclusions are really listed here for possible DMT discontinuation or de-escalation, and that is that there are a number of factors that are potentially relevant to recurrent MS risk should you do a trial off of disease-modifying therapy. And age, with a very low apparent risk of relapse above age 60. Recent disease activity, certainly 10 years or longer, the vast majority of people, especially over the age of 60, are not going to have new relapses. Mechanism of action may make a difference, as in that French study that I went through in detail, but we don't really know yet if that's true in older, truly stable patients like the disco patients. But it's important to remember today, as of July 1, 2025, there is no age at which we conclude that MS has clearly stopped being active. If you have done this long enough, we've all seen people in their 70s have acute relapses. It's just incredibly uncommon. And so we never really can say that the MS is clearly stopped being active. We can just say that the risk gets lower and lower and lower. And then the question is someone willing to undergo that risk? But in long-term stable patients, over 60 years of age, the greatest disease recurrence risk is a small number of new brain lesions of unclear long-term significance. And in our study, at least out to 3 to 4 years, really no increased progression of disability or anything like that. But each individual has individual course over time, and we cannot perfectly predict this. So one of our colleagues at Cleveland Clinic is trying to take our data and looking at their data in their own database to try and answer the question, can we come up with a specific risk based on one individual looking at age, disease duration, time since last relapse, time since last MRI scan change, and all these other factors, and come up with a risk score, if you will, and a risk algorithm. And so we'll see. We have a poster presentation at ECTRIMS in the fall in Barcelona on the original data, and then we'll see what it looks like over time when we look at multiple other populations as well. For those who are uncomfortable with DMT discontinuation, de-escalation may be a rational first approach, or you could, of course, continue to use your DMT and then just reassess as time goes on. But when you discontinue or de-escalate, ongoing monitoring should be done. There's no formal algorithm. What we have always done, what I've always done, is make sure the baseline scan is unchanged, the exam is unchanged, and then we'll scan again at 1 year, scan again at 2 years, and with the assumption that everything is stable, then we may not check at all or only check as needed should someone have new problems. Again, looking at a population of people who are relatively quite stable. Serum biomarkers have not been found to be useful as yet in this context, but they may be, and we're always looking at new markers or MRI markers or other things that might say, you know, this person might be pretty good discontinuing, this person may not be. We haven't yet gotten to that level with serum biomarkers yet. And it's also extremely important to remember that worsening disability, worsening progression on the EDSS scale with aging may be due to factors other than MS. As we age, unfortunately, we have a number of things that may also happen. Some people may develop congestive heart failure and they don't walk as well because of that. Some people may need to have their hip or their knees replaced and they don't walk as well because of that. Other people may have other reasons to have any of a variety of other symptoms that can overlap with MS. So it's the job of the neurologist as people age to make sure that we're saying that, hey, the change that you're noticing is due to MS or it's not. And if not, then it's our job to try and figure out what is causing that problem. So on to a couple of other topics here. And these were some of the questions that were asked by those who put their questions in so far. And thank you for asking those questions. So can blocking CD40 ligand activity decrease MS activity? And your first question, of course, is what the heck is CD40? So CD40 is a protein on the outside of white blood cells, and the CD40 ligand is a protein on the outside of different white blood cells, and they hook up. And the CD40, this protein is expressed primarily on B cells, B lymphocytes, but also other so-called antigen-presenting cells that present chunks of viruses, bacteria, and other things to other immune cells to rev up the immune system. So these are so-called antigen-presenting cells, and they function as a receptor that binds to the CD40 ligand on other cells, and those are primarily activated CD4 T cells, but also seen on some other cells, even platelets. And these two hook up, and when they hook up, as I'll show in the next slide here, this activates the immune system in a variety of different ways. So we have B cells, CD8 T cells, macrophages, and dendritic cells, and they will, via the T cell receptor, they will bring an antigen to the T cell receptor. But they do that by essentially docking with the CD4 connecting to the CD40 connecting to the CD40 ligand. And that essentially hooks it on there, and then they present the antigen. This results in downstream changes in a variety of different cells, especially activating the B cell itself. So that B cell will present the antigen and then will be activated by the T cell. and the same for the CD8 T cell. And we showed a decade ago, we showed that these cells were relevant because we looked with our colleagues at the Webb Waring Institute and we looked at type 1 diabetics, and we showed that expression of the CD40 ligand on, CD40 on activated T cells went up in type 1 diabetes. And there are some interesting correlations between type 1 diabetes, which is an autoimmune disease, and MS. And that's compared to controls or type 2 diabetics. So we said, well, what about in MS patients? Can we see an increased expression of this marker on these cells in MS? And the answer was yes. And there's almost no overlap in the number of cells that are expressing this between the MS patients and the type 1 diabetics and controls or type 2 diabetics. There's a slight increase with age, and we can see this in relapsing MS, in primary progressive MS, as well as in secondary progressive MS, being slightly higher amongst those because those are older patients. So even a decade ago, we showed that this was potentially relevant in MS, and a number of other studies have looked at this, this docking of CD40 with CD40 ligand and shown a variety of different things in terms of initiating both the innate and adaptive immune systems. It's associated with MS and progression of disease. We can see elevated levels of expression on the active cells themselves, but also soluble CD40 ligand that is floating around in the blood, and this correlates with disability. We know that there are some mutations genetically in the CD40 gene that's associated with MS risk. It's one of the MS risk genes. And so blocking this CD40 ligand interaction was studied first in a first generation monoclonal antibody blocker, but there were a lot of blood clots in those patients, and that drug was abandoned. Molecules were re-engineered, and now a second generation monoclonal antibody against CD40 ligand has begun studies. This is called frexalimab, and I'll show you that data here. So this is a phase 2 study looking primarily at the change in active lesions on scan from week 8 to week 12 compared to placebo, and looked at 2 different doses and delivery devices for the frexalimab, 300 milligrams subcutaneously every 2 weeks, or frexalimab 1,200 milligrams IV every 4 weeks compared to placebo. So each one was individually compared to placebo, and this is the combined placebo. And between 8 and 12 weeks after that, you can see a substantial reduction, essentially almost no new disease activity amongst the 92 or so patients here who got rescanned at week 8 and week 12. On the basis of this, they then did a long-term extension, and this was just reported literally a month ago at the Consortium of MS Centers in San Diego. And they looked at people who got transition. All the placebo people got transition, either one of the 2 doses of the frexalimab, and those who were the original people on frexalimab as well. And the primary outcome measure here was mean number of these new active gadolinium-enhancing lesions. And looking at 96 weeks now, not just the 12 weeks from that original study, there's almost no new activity with the gadolinium-enhancing lesions, especially with the 1,200 milligram dose every 4 weeks, almost uncountable. And then also when you look at just the little white dots on the brain scan, not the active lesions, but just general lesions, same dose was very, very low numbers. They also looked at annualized relapse rate, which was very low at 0.08%. 92% of people, this is now at 2 years, were free of relapse, and no change in EDSS disability on active therapy. And importantly, only 1 person had a blood clot over the 100 people that were taking the drug. So they seem to have fixed the blood clot problem. These are now in phase 3 trials in both relapsing forms of MS as well as in non-relapsing secondary progressive MS. Keep that in your head for a moment while we talk about the next drug. That means these are individuals who have started to have slow progression independent of relapse activity with no relapses for at least 2 years. So this is the greatest unmet need in multiple sclerosis therapy because there is no drug that has been proven to be beneficial in this population of individuals. So those are underway, and you can see they'll be reported out in 26 and 27. Let's talk about tyrosine kinase inhibitors. If you went to the recent webinar with Dr. Alvarez, he talked about this quite a bit. Um, there are many different tyrosine kinases. These are proteins, enzymes, tyrosine kinases. And what they do is they take a phosphate group from one molecule and move it to a different molecule. That's all they do. And there are these tyrosine kinases all over your body, and this little small change of moving a phosphate group will have a profound impact on the cells after they interact, because that will start downstream effects to occur in a variety of different cells all over your body. But there are some that are specific relatively to the immune system, some of which are just so-called generic tyrosine kinase inhibitors, so enzyme blockers. One is masitinib. Masitinib has already been shown to be helpful in progressive MS, showing a reduction of 30%, 37% in progression of disability compared to placebo. And there are ongoing studies with this. And as I'll show you in a minute, the reason why this is going to work in progression of disability has to do with targeting the macrophages. But there's also a subclass of the tyrosine kinase inhibitors or tyrosine kinases. And they're called the Bruton's tyrosine kinases, or BTK, and the drugs that inhibit them are BTK inhibitors. These are cell surface molecules expressed by all sorts of cells in the blood lineage, except for not in T cells, not in natural killer cells, and not in plasma cells. And they're primarily affecting B cells and macrophages and microglia. And there are multiple different inhibitors of these with different properties. The effects of blocking this may be seen in both relapsing MS as well as in progressive MS for reasons that I'll show you here. So when you have an antigen that has presented to the B cell receptor, so there's a virus, bacteria, something else, this chunk of material, there's a B lymphocyte in your body which can attach to this. This is how the immune system works. They're like surveillance systems. They attach to it. And when that happens, it starts a downstream reaction inside the B lymphocyte. And almost immediately, the Bruton's tyrosine kinases, this is a major, like, second step, will start then converting a variety of other molecules into other things in the cytoplasm and also in the nucleus, affecting the DNA and RNA of the actual cell, in this case, a B cell. If you block this, none of these things occur. And that would stop a variety of different things from happening. And we can see that these kinases are not just on B cells, but they're also inside of macrophages and microglia. So you could affect both the B cells and macrophages and microglia at the same time, with the macrophages and microglia being extremely important in individuals with progressive MS, the B cells being important for both relapsing patients and progressive MS patients. And so there are now at least three, there's actually another one, a fourth one, of Bruton's tyrosine kinases, BTK inhibitors, none of which are approved as yet, under study. The first to give us phase 3 data was from evobrutinib, and they did a relapsing remitting MS trial over 2 years. And unfortunately, this failed. It failed to show a benefit. And in fact, there was actually even compared to Aubagio, there's maybe even perhaps a higher level of MRI activity compared to this drug. And this drug was then abandoned. Fenebrutinib has both a relapsing MS study and a primary progressive MS study underway in phase 3, and they're going to read out. There's a couple different relapsing studies going to read out in the end of this year and early next year. The primary progressive MS trial is compared, interestingly, to Ocrevus, because this drug is owned by Roche Genentech, who owns Ocrevus as well, and they're comparing in a non-inferiority study directly to the new molecule in a phase 3 study that's going to read out in a couple more months. we're going to spend a little time talking about tolobrutinib, the third agent here. And this has recently failed a phase 3 relapsing remitting trial, as I'll show you in a moment. But there are positive results in a non-relapsing secondary progressive MS trial in a phase 3 trial. And this drug is now in front of the FDA for approval based on that and some of the data from this failed relapsing MS study with a so-called PDUFA date. That is the date by which the FDA targets for a decision. And this is on the rapid or fast track. So we'll see this result potentially in another 3 months or so. And what do we see? So in the phase 2 trials, they looked at multiple different doses compared to placebo and just looked at the number of lesions that were active that were detected after 12 weeks. And you can look at the higher dose, the 60 milligrams taken orally, and this is a drug that penetrates and goes into the brain, unlike many of the drugs that we presently use now, which really do their business outside of the nervous system. When you look at the reduction in actual T2 lesions, substantially lower than placebo, and the gadolinium-enhancing lesions substantially lower than placebo. This then generated the phase 3 trial, which I mentioned a moment ago, because this was in relapsing remitting MS patients that failed. And this was called the Gemini 1 and Gemini 2. This was compared to Aubagio over a 2-year period of time, 2 identical studies. And what they showed was an annualized relapse rate that was 0.12, higher than, if you can remember what the frexalimab was, which was at 0.08. But it was in both groups. So it was no better than Aubagio, which is considered one of our weaker medications. In both studies, there was a higher number of gadolinium-enhancing lesions with tolobrutinib, and in both studies, there was a slightly higher number of T2 lesions with tolobrutinib. But interestingly, disability progression was less with tolobrutinib, and disability improvement, although not statistically significant, was greater with tolobrutinib. So no real impact on the relapses and active lesions, but interestingly slowed progression. And that data is here. And you can count disability worsening or progression of disability that is confirmed at 6 months in the top or 3 months in the middle here, showing that the Aubagio, the teriflunomide, had more people with progression of disability in both cases. And then also, if you look at disability improvement, it was greater with tolobrutinib, not with Aubagio, although this was not statistically significant. And so it was interesting to see that it failed with relapses, just as evobrutinib had, but the tolobrutinib did well with regard to slowing progression of disability. Notably, the one potential side effect that is of concern is a very small number of people can have significant liver function abnormalities, so less than 1% of individuals noted at the bottom here. And that was one of the warning signs that came out of the tolobrutinib study originally, and actually halted the study with recruitment for a while. And so if this drug gets approved, it will likely have a marker on it saying that you're required to do over the first 6 months, maybe monthly or more frequent monitoring for liver function abnormalities, because that's when the abnormalities that seem to occur is very early, and the vast majority of people do not get it. So, as I mentioned, they also had a non-relapsing secondary progressive MS trial. And what did they show there is a phase 3 trial, randomized 2-to-1 against placebo, because there is no drug that's known to treat non-relapsing secondary progressive MS. And these individuals had to have no relapse for at least the last 2 years. The average was actually about 5 years. And the primary endpoint was confirmed disability that was sustained for at least 6 months, and that's what we see at the top, or sustained for 3 months. That's what we see here. And we see a number of people who actually improved here. And as it turns out, the average time since the start of so-called secondary progressive MS was 8 years. Average time since last relapse was actually not 5 years, was 7.5 years. And about 13% had active lesions at baseline. So there's some degree of activity, even though people were not having relapses, but about 1 in every 8 people had active lesions on their scans. And so placebo had a higher risk over time of having progression of disability confirmed at 6 months and confirmed at 3 months. And in addition, a higher number of people on tolobrutinib had improvement of their EDSS score. And in addition, 38% less new lesions were seen with the brain MRI scan using tolobrutinib compared to placebo. So interestingly, there seems to be an impact that is greater, that is more easily measured with progressive disease with this medication than with relapsing MS. And on the basis of this study specifically, as well as I'm not sure if they actually added the data in, the data will go to the FDA, but whether or not they count the data from the relapsing MS study showing a similar impact on progression of disability, we'll now see if the FDA approves this in September. In this study as well, there was a very small number of people with the liver function abnormalities as noted here. So again, consistent with the other studies. So we'll see what happens with the BTK inhibitors. There's more news to come over the course of the next 2 years, but the PDUFA date for tolobrutinib with non-relapsing secondary progressive MS is just a couple months from now. So switching gears entirely, we have spent a lot of time in the last 30 years or longer trying to figure out how can we predict disease severity. This is important because it will help define, for example, medications that we use, how long we use them, doses that we may use for them, just telling patients what to expect with their life. So predicting the level of disease severity has been one of the major questions that we've been addressing for quite a while. And there are markers, both clinical and MRI, but also serum biomarkers, which are helpful here, like neurofilament light. There's spinal fluid markers. There's some contrasting data with oligoclonal bands, but now there's a study that was just published, wasn't actually published, it was actually just at the American Academy of Neurology a couple of months ago, looking at the kappa-free light chains that showed if you have these very early on in disease activity when you're first diagnosed, then that is a marker of disease severity. But are there genetic markers? We know there are over 230 markers of risk factor for developing MS that are genetic, so-called single nucleotide polymorphisms, or SNPs, but also you can just think of them as a mutation. There's a change in the DNA code, and it's associated with the change in the performance of that gene. And there are very few genes, if any, that have been identified that are associated with risk of disease severity. But this particular SNP, and it's they're all named in this relatively arcane way with all these numbers. But there's one specific and up to 11 others that the International MS Genetics Consortium identified in 2023 that could be potentially related to severity. And others, both in the Annals of Neurology, which I help edit, as also as well in the International Journal of Molecular Science just recently, both studies from 2025, have shown that there's a relationship between this particular gene, this particular SNP, if you will, and disease severity. And it's been associated with faster time using a walking aid, like a cane, or 6 months confirmed disability worsening, or more MRI lesions, brain atrophy in a variety of different studies that I've marked here, including faster retinal nerve thinning. This is thinning in the back of your eye, which is often associated with optic neuritis, which was just at the European Academy of Neurology a couple of weeks ago, as well as more recently as well with pathological changes. But there have been some conflicting reports as well. And the conflicting reports also in our journal, the Annals of Neurology, as well as MS Journal and Brain Communications from last year, showing that they were unable to show any significant relationship with disease severity. So it's sort of a mixed bag, and we're not sure where this is going to go, but it certainly would be useful if we could identify a marker or a series of markers in a blood test when you newly diagnose someone and say, you know, I think that this is going to be a mild version, a medium version, or a severe version of this condition for you, and then you could act appropriately with regard potentially to choosing various therapies, for example. So there's going to be more to hear about this, but this is where we're going, and there might well be other markers that are MRI markers or serum biomarkers that are also helpful. But having this kind of information is extremely important for patients and their families. So in summary, we have new diagnostic criteria for MS that lessens barriers, improves specificity and sensitivity. So being right and being right when you need to be right. Recent studies confirm that age and recency of disease activity are major predictors of disease recurrence after discontinuation of DMTs, but there's still some risk, mostly brain MRI lesions, even in older stable patients, for example, over age 60. And what is the significance, excuse me, of one or two new brain MRI scan lesions? The reality is we don't know. But in working with our European colleagues, we're trying to answer that question. We're going to be looking at a variety of databases around the world and ask the questions when people have discontinued their disease-modifying therapy and they had new disease activity, what happened to them after that? And from our data so far in the DISCO study, the answer is not much, other than seeing some dots on a brain scan. But the real answer is we need much more data. And so we'll hopefully have that in the next 6 to 12 months. There's an ongoing search for markers of disease activity, especially genes, as I mentioned. Frexalimab and the BTK inhibitors are coming into phase 3 trials. BTK inhibitors, we're going to see what happens with tolebrutinib in the very short term. But these are two new classes of medications. These are not just retreads of different medications. So we have the fifth new drug that's in the same class, and we already have 4 other drugs. These are novel mechanisms of action, and both of them have potential promise with secondary progressive and primary progressive MS as well. We'll see how the data plays out. So thank you very much for your attention. I'm going to stop sharing, and then I'm going to go to many of the questions. And so just bear with me for a moment while I pull up the questions here. And many of the questions we've already answered. So if I don't specifically get to your question, please know that either we just couldn't get to it in time, and the reminder for Conversations MS, which is really more of a question-oriented format, but also that many of the questions were already answered in the slides that have been presented. But there was one question about, for example, how long are DMTs recommended for use with the new therapies, with the, say, Tysabri or Ocrevus, for example, and how long is it recommended to take these? And the answer is it's going to depend on the individual, like everything else. If someone is young and they're newly diagnosed and they go on one of the medications, they may be on for many years because these drugs do not change the risk 20 years later. They change the risk now, and then the risk will change over time from the natural history. But as opposed to, say, when you treat cancer and you remove what you can, then use chemotherapy and X-ray therapy, that changes your risk now, but also changes your risk later. The risk change that occurs with MS will occur from the natural history of disease. The drug doesn't change that except for reducing the activity. But if you stop the drug, you're going to go back to having whatever is your sort of age and disease appropriate level of activity. So this is a chronic use approach. And a related question that came up with this was, well, how come I don't feel better, essentially? Why is it that we don't notice any change in how we feel? And the reason why is that what this class of drugs broadly does is not to treat symptoms or the places that have already had some immune attack against the nervous system. What they do is they will actually alter the natural history of the disease. So you reduce relapses, you reduce progression of disability, you reduce new lesions, you reduce brain atrophy. And those are the things that you see, but they do not, unfortunately, in the majority of cases, change, say, what your brain scan looks like. If the lesion is there on your brain scan, it will have a natural history where it changes in terms of enhancement and whether or not it has a phase rim, whether or not it's associated with a so-called dark hole or black hole on T1 imaging. But it doesn't make that lesion go away. It doesn't cure the lesion. And so the reason why we don't have that kind of symptomatic change is that. Now, that said, as I just showed you, sometimes you can see improvement of someone's disability score. And that improvement presumably reflects the fact that you've altered the inflammation and there's been some normal recovery that has occurred. So there can be recovery, but the recovery is relatively modest, and majority of individuals really do not get that. There were questions about cancer risk with drugs such as Ocrevus, as I mentioned, and was seen in the phase 3 trials and phase 2, well, phase 3 trials really with Ocrevus. There was a small increased risk potentially of breast cancer seen in the Ocrevus original trials, and there's a black box warning related to that. And a meta-analysis of all of the different studies looking at age as it's related to risk factors of cancers and infections and things like that suggests that the depleting agents, as I mentioned, Ocrevus, rituximab, Lemtrada, mitoxantrone, novantrone, drugs like that probably have a very small increased risk of cancer, but it's relatively small. And in longer term studies, for example, post-marketing studies with Ocrevus specifically, there has not been found a significant increase or any increase really of breast cancer to date. But I think it's still a black box warning. We still tell people about it. It's still something we pay attention to, and we'll see over time if there is an increased risk. But if that is, from the data that we presently have, it's a very small increased risk and not restricted just to Ocrevus. It's probably with any of the agents that deplete cells and remove them from your armamentarium of your immune system. We had another question with regard to the use of the cell depleting agents. If a person decides to continue taking those, that may deplete your immune system and your ability to fight off an infection. What can you do about that? How can you help combat that issue? Well, I mentioned one way to combat that issue is to change to a different class of drugs that doesn't have that risk, or you can lower the dose. So those are ways to de-escalate the therapy in the face of risk, again, especially as we age when the risk may go up. You can sometimes just increase surveillance for the infections. Have a very low threshold, for example, for checking for urinary tract infections. If someone is wheelchair bound or bed bound, to make sure that they get excellent skin care, because that can be a major problem. The 3 big infections that are very concerning, especially as people age, are what we call wind, wound, and water. Wind is pneumonia. Wound is a skin breakdown, and water is a urinary tract. That's the sort of mnemonic that we go by that reminds us of the 3 big infections with people who have say, inability to walk. And so increased surveillance can help. If someone has a very low white blood cell count, is there anything that you can do to bring that up? There are some drugs that can do that. You can sort of force the bone marrow to release them earlier. Sometimes in younger patients, that can be associated with risk of having a relapse, so that's a concern. What about if someone's antibody levels, their immunoglobulins are low? Well, then you can also just give intravenous or subcutaneous immunoglobulins, and you have to do that sort of perpetually until the normal return of the immunoglobulins, but it has to be done roughly every 4 to 6 weeks. And so that you can do as well. Some things you can vaccinate for. So for example, we know that the outcomes with the anti-CD20 drugs like Ocrevus and rituximab, if you get exposed to COVID, are higher. So getting COVID vaccination reduces the risk and the severity of developing COVID. And that's an example of the way vaccines can help. So that's another thing you can do to reduce risk, but that's only for the infections that we have known vaccines for, and many viruses we don't have vaccines for. So that is not going to help you with every infection. So there are a lot of things that you can do to help deal with the risk of infections. One other question had to do with restarting medications after discontinuing medications. When would you do that? That's also unclear. And as I mentioned a moment ago, we're working with our European colleagues to try to understand if someone has new disease activity, especially one or two new dots on their brain scan. What does that risk mean to them a year later, 2 years later, 5 years later, with regard to risk of having a relapse, risk of having a progression of disability, or anything like that? So we're going to try and get at understanding what that means, which would be the first helpful thing. The second is, right now, while we don't have that information, is ongoing. So there's three choices. When this comes up for my patients, I would always say we have at least three choices here. One, we change nothing. We just check your exam every 6 months, check your scan in a year, and then we'll see what happens. A second option is to increase surveillance. So if you have an active scan, if you don't want to go back on medication right away, we would scan you at 6 months, not 12 months. So scan at 6 months, and if that's quiet, then go to 12 months. But increase surveillance. The third option, of course, is to go back on medication. And the data that exists so far would suggest in different populations, not in an older stable population overall who have discontinued their medications, but the data that does exist suggests that minimal evidence of disease activity, that is a dot or two on your brain scan, is really no different from no evidence of disease activity. And actually, when we say no evidence of disease activity, we call it NEDA 3, that is no relapse, no scan change, and no progression of disability. NEDA and MEDA, or MEDA, minimal evidence of disease activity, which is no relapse, no change in disability, but maybe one or two dots on your brain scan, but not more than that. There are multiple studies that show that one or two dots on your brain scan, essentially at 1 year after starting medication, a different context that we're talking about discontinuation, but in that context, are not associated with new progression of disability over 5 to 10 years. And that's in fact why for the DOT-MS study, the Amsterdam study that was very similar to the DISCO-MS study, they chose 3 or more lesions as their primary outcome measure with relapse, as opposed to just any new brain lesion, because one new dot, two new dots really don't predict new clinical activity, at least as far as we know. So the reality is that we still have more to learn about this, but for right now, those would be the options I would offer to people. And most people with just a single new dot on their brain scan would just elect to have their scan done again at 6 months. Most of the time, in that case, the vast majority of the time, we see nothing at 6 months and go back to our routine monitoring, and the patient does well. But I don't have any formal data on that. We're working on the formal data.
Dr. Corboy?
Yep.
We have just a couple minutes left. Are you able to see the Q&A box on Zoom for the questions that were asked
Sure.
live?
Sure. Q&A, there's 5 questions. Let's see what we can get to here.
Thank you.
To diagnose secondary progressive MS, you do not have to have spinal cord lesions. So the question is, do you have to have them? But most people do. But if it's just brain lesions and symptoms in space and time with progression, that would be secondary progressive MS. Not required, but the vast majority of people will have spinal cord lesions. Second question, many of the studies did not deal with the B-cell depleting meds. Is there likely to be any difference in the answer when you look at those drugs? Well, we sort of answered that with the French study, and at least in the context of the French study that I mentioned, the OFSEP study, that in that patient population, the CD20 drugs discontinuation did not result in worse risk of relapse or worse risk of development of disability. Another question is, have de-escalation but not discontinuation studies been done on interferons? Yeah, they have been done with them, and they show pretty much the same thing as the discontinuation studies show. That is, your highest risk is going to be is going to be seen if you de-escalate to something else. I'm trying to think of an example. There's not much to de-escalate to that's below an interferon. Interferons are considered perhaps our weakest drugs, that or Aubagio or Copaxone. So I'd have to go back to look to see explicitly how they're really more switch studies than if you went from interferon to, say, Copaxone or something like that. But we don't really have the ability to de-escalate beyond interferons because they're really the weakest drugs we use. Are any of these markers in the biobank data? I'm not sure what that means, unless they're referring to the genetic markers, and those are in biobanks. And there's the UK Biobank has a ton of data, including genetic data, but there's also genetic data banks with the International MS Genetic Consortium. So I'm not sure what that question actually means. And so if you put that question out there, if you want to try and maybe rephrase it, we'll try to get back to it. Final question, is it worth talking to my doctor about the SNPs, like the one that you mentioned there, for better understanding potential severity? I would say at this point, the answer is no, just because the data is still conflicting and it's evolving. All the studies I showed were published in the last 12 months, and I don't think we would have a definitive answer for that. So the answer today would be that our bias is still to, when someone is diagnosed, and this gets to another person's question, to treat as quickly as possible. And with today's data, the argument would be to use the most highly effective therapy available. Some, for a variety of reasons, some people can't use some therapies. For example, if you have been exposed to the JC virus, using natalizumab, Tysabri is maybe not the best choice. So that's an example of being limited by a test that told you about a prior viral exposure. But on the whole, to use the most highly effective therapy available, because numerous studies show that the outcomes are better should you be treated early, and to be treated early with highly effective therapy. And then the question becomes, over time, do we develop better markers of disease severity, and how does that frame what you use over time? Right now, we just don't have that answer, and so I don't think it would be useful to try and get that gene. And I'm not even sure how you would get that. I mean, you can't get it just like through 23andMe, for example. I'm not sure how you can get that right now. These are all just research studies. Question, I was recently diagnosed. I have a large white matter, presumably a large white matter burden with many lesions. I'm 37 and experience severe memory loss and tingling arms, legs. How do I relieve these symptoms? That's a symptom question. That's a whole topic in and of itself. And there are some other questions about spasticity, neuropathic pain, and others that were in there. Those are very good questions for the conversations in MS. But there are a variety of symptomatic therapies that are appropriate for tinglings in the arm and the legs. Typically, if you have pain, the medications do better. Memory loss is multifactorial, and first understanding what the cause of the memory loss is first. And again, like with everything in MS, trying to make sure that we blame some things on the MS, and then there may be other issues that are also relevant. Another question was, UCL has a biobank that captures samples and gets screened, but genetic data is always evolving like this. You mentioned genetic markers. So if an individual had biobank data submitted, and these genetic markers exist or don't exist in this one, that is a part of the genetic screening of the biobanks. So yes, we're not sure as the markers identified, but not always revisited. I think what the patient's asking with this is, just for those that do not know, there is a biobank at the University of Colorado Hospital, and many of our patients have participated in this. And we have actually used the biobank in a study that we have a paper under review now, because we, for example, looked at our first-degree relatives of individuals with MS, the first-degree relatives being asymptomatic, and we tried to determine if we could say that the changes we see in our own biobank are similar to those that are seen genetically in the first degree relatives that have asymptomatic lesions on their brain scan that are concerning for MS compared to the first degree relatives who do not have changes on their brain scan. So we call this the RISE MS and the DREAM study. And our data so far shows that if you look at the biobank, the same biobank that this questioner asked about, we can identify a collection of different nerves that came up, of mutations related to immunologic or nervous system function that are seen in MS patients. And if you collect them all, you can do what's called a ROC analysis, and you can see what the likelihood is that that's relevant in defining risk of developing MS. So these are known MS patients. And then we can use the exact same number and type of mutations that we can see in the population we're interested in, the first degree relatives who are asymmetric but have a MRI scan that looks like it's at risk for MS. And we can see that the overlap is very high. Whereas the people who are first degree relatives who do not have a lesion on their scan, these are young people, aged 10 to 30, they don't look the same. They look like they have a risk that's like in the general population. So that's one way that you can use the data. But in terms of if I think that the questioner is asking, do they have the ability to go back and get answers about whether or not they have risks in the, if information like this becomes developed, can you say, oh, can you please tell me what my SNP score is for these, 36 SNPs that might be relevant? I don't know what the agreement is with the biobank as to how they make any of that kind of information available. So I don't actually honestly know the answer to that question.
We are a bit over time today, so I do want to say thank you, Dr. Corboy, for all of your time today. And thank you, everyone who submitted questions. Again, this webinar will be archived on YouTube. And if you've got questions that were not answered tonight, I do encourage you to tune into Conversations on MS, with the next session being July 11th. And those happen almost monthly throughout the year. So thank you all, and be sure to sign up for our mailing list to hear about future programs.
Thanks for coming, everybody.